Good evening, and thank you for joining us for the Paediatric Respiratory Presentations to ED webinar tonight in partnership with St George Hospital. My name is Michaela, and I'm the Practice Nurse Liaison Program Officer here at CESPHN. Also online tonight is my colleague Giuliani. Giuliani will also be assisting with questions. So I'd like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past and present. I'd also extend that respect to any Aboriginal colleagues who may be joining us tonight. Just before we get into the presentation, just a little bit of housekeeping. So please note that this session will be recorded and will be available on the CESPHN YouTube channel within the next couple of days. And please submit any of your questions that you may have into the Q&A function at the bottom of your screen, and we'll have about 5 or 10 minutes at the end to answer those questions. Also, at the end of the webinar, an evaluation survey will pop up on your screens and a follow-up email will be sent out tomorrow. We do appreciate your feedback, so if you could please complete the evaluation survey, this will also allow us to issue you your certificate of attendance. As you can see, we've got some Practice Nurse networking events coming up. So if you'd like to register, you can do so through our website or via the QR code there on your screen now. We also have some information there on the integrated care group for the Chronic Diseases Network. If any of you would like to join, please just scan the QR code there, or you can send an email through to Kylie, and her email address is there on the screen. So now I'd like to introduce you to our speaker tonight, Claire Rowe. So Claire is an AHPRA-endorsed emergency nurse practitioner with over 26 years of emergency medicine experience. Claire started her career as a staff nurse, then an RN, CNS, CNE, CNC, and finally, after completing her Masters of Nursing, nurse practitioner, she then became a nurse practitioner. Claire has dedicated her career to improving patient outcomes in fast-paced, high-stakes settings. She also holds certifications in paediatrics and APLS. She has always worked in mixed emergency departments and had a passion for paediatrics. As a nurse practitioner, Claire has the honour of being able to see, treat, diagnose, prescribe and refer patients collaboratively and independently. Another part of her role is she's a sexual assault nurse examiner, carrying out medical forensic examinations on victims of sexual assault. So I'd now like to hand over to you, Claire, to get us underway with the presentation tonight. Thank you.
No worries. Thank you. Can you hear me okay?
We can.
Okay, good. I'm going to presume so. Hello. Thank you very much for that introduction, and thank you for asking me to come and speak. So I'm going to touch on paediatric respiratory presentations. As I'm sure you know, an hour is a very short period of time to go over a very large topic in the paediatric population. But let's do our best. I tend to talk quick, so if I'm talking too quick, just raise a hand or put something in the chat. I also don't want to talk at you for an hour, so I will be asking for a little bit of interactive time. And again, just there's a chat at the bottom there. If you've got any questions or you want to answer a question, just write your stuff down in there. So we'll start with the paediatric respiratory presentations. I'm going to give a quick sort of overview of anatomy and physiology. Then we'll do some case presentations. And basically what I'm hoping to do with these case presentations is represent most common presentations, I'm sure, to doctors and to emergency departments, and then talk about the importance of follow-up. Oh, my screen is not moving. Again, next screen, thank you. So already had a quick introduction, but my name's Claire. I do have 25 years emergency nursing experience. Been an emergency nurse practitioner for I think it's about 6 or 7 years now. I've always had a bias towards pediatrics. I enjoy working with that population. But also, I think what helps working with that population is I'm also a very proud mother of 4 boys. So I think it gives you a lot of insight into pediatrics when you've had your own. Not you need to have your own to have it, but it always helps. I've done my undergraduate, then I did my crit care. I've done some work, adult and workplace learning, exams and things like that, and then also my sexual cert nurse examiner course, and then most recently, probably that was about 4 or 5 years ago, I did the Sydney Child Health Program, which is what they get most of the junior doctors and registrars if you're going to work in like sort of the Sydney Children's Hospital and Westmead Children's. It's one of the foundation courses that they get for them to do as well, because it gives you a look into most pediatric presentations that you may see. And then your next slide, please. So what's an MP? I'm not sure how many are sort of out in the community in primary care setting. I know there are some. I'm going to jump over this a little bit. It's basic in a vast practice nurse who specializes in providing care in emergency settings. We've got lots of different education and training. We practice within a particular scope of practice. So I'm an emergency nurse practitioner. I can treat, prescribe, refer, diagnose within my scope of practice. I can't tomorrow go and work in oncology and suddenly be an oncology nurse practitioner. You stay within your scope of practice. Lots of different roles and responsibilities in emergency, a bit like you guys in the GP world. You basically see anything, a bit of anything and a bit of everything, from newborn until death, from trauma to cardiovascular emergencies to minor injuries. It's a really fulfilling job to be able to do so much and experience so much within your working practice. Next slide, please. So what do we see? Mostly fast track and pediatric patients. We do give supplementary support in other areas like resus main halls, our short stay units. We cover all ages, newborn, children, teenagers, adults and elderly, and lots of different presentations. We do musculoskeletal wounds, fevers, respiratory, pregnancy complications, diarrhea, vomiting, rashes, foreign bodies, masses, lumps, sexual assault, and there's probably a few more. That's just a few. I won't bore you too much more with the rest of it. And then the next slide, please. So now we're going to the pediatric respiratory presentation. So with it, as with anything, like having a sound anatomical knowledge of what is happening really helps your practice. So differences to adults: pediatric patients have a smaller airway. Infants particularly are obligatory nose breathers, more usually so that they can actually feed. They've got a large tongue. Their airway is more anterior, narrower airways and are shorter to clear than adults. And the narrowest part is at the cricoid ring. The metabolic rate is twice that of an adult with twice the oxygen consumption. So along with twice the oxygen consumption, if you've got twice the metabolic rate, what's the other parameter that we have to keep a close eye on in pediatrics? Their sugar, their glucose. So you might have a respiratory patient and you're worried about their oxygen, but you also need to worry about their glucose. Next slide, please. So their breathing, their rate is 2 to 3 times faster than that of an adult. The alveoli is less elastic, has less elastic recoil and less supportive elastic tissue. The lung tidal volume is approximately 10 mil per kilogram compared to that of an adult, which is up to 500 mils. The diaphragm is a major muscle for respiration. It can become very easily fatigued. Supporting airway cartilage and small airway muscles are incompletely developed until they are 5 years old, and that laryngospasm and bronchospasm can lead to a full airway obstruction. So next. Okay, so it's really important to recognize a child in respiratory distress. So here are some of the signs that you have. So tracheal tug, chest recession, tachypnea, color, nasal flaring, position or of comfort, and their behavior. Smaller kids, babies and infants will have some head bobbing happening there as well. Then we're just going to go a little bit of respiratory terminology because we're going to use a little bit of that throughout the talk. So respiratory rate, or RR, is the number of breaths in a whole minute, so full 60 seconds. Work of breathing, WOB, is the amount of oxygen and energy needed by the respiratory muscles to produce enough ventilation and respiration to meet the metabolic demands. What are some examples of increased work of breathing? I'm not sure whether you can really answer apart from down here. No. Okay, next. Okay, where are we? And I was going to ask you what's a tracheal tug, what's a wheeze, and what's a stridor, but I think it's a bit difficult for you guys to answer. Is that right? Okay, so I'll just keep going. Next page, please. Okay, so recognition of a sick child, particularly respiratory. So they'll have an increased work of breathing. So that means they may have a tracheal tug, chest recession, tachypnea, or very fast breathing. Their color may be different. They may have nasal flaring. They may have a particular position of comfort, and their behavior, they may be lethargic, they may be grumpy, they may be crying. Yeah, next slide, please. So cyanosis is a very late and pre-terminal sign. It's not something you want to see in a baby or children, is cyanosis. Next page, please. So now we get on to the different case presentations. Next slide, please. So I think I've got 4 here, and they're all 4 patients that I saw. So I've given you a little bit of triage and then how I've worked them up. Okay, so this is a little 2-year-old called Sophia. Obviously, these aren't their real names. At triage, she's triaged with a 2-day history of fever and increased work of breathing, associated with coughing, decreased appetite, less wet nappies. She is alert, she's interactive, she's got mild increased work of breathing, moist mucous membranes, but she's febrile. So she's put on a category 3, which means they need to be seen within 30 minutes. I can't ask you what else you need to know because it's a bit too difficult to answer. Next page. Sorry, next slide, please.
Sorry, Claire, I'll just quickly mention that you can type your answers into the chat, and then we should be able to see those there for you, Claire.
Okay, thank you. Okay, no worries, thank you. I'll wait for a few seconds the next time, then give you a chance to type. So my own history. So a 2-year-old female. So fevers for 1.5 days, up to 39.5. Measured on a tympanic membrane, given Nurofen with effect, given last night. Now, there's a few things that are really important when you're looking at kids with temperatures in the respiratory setting and in any setting. You want to know how high it's gone. You want to know how it was measured. A lot of children get their temperatures measured tympanically. Now, she's 2 years old. Is this the best way to measure a 2-year-old's fever? I'll give you a few minutes to type your answers. Okay, I can't see if there's any answers, sorry.
Someone
Okay,
has said yes.
Sorry?
Someone has answered yes.
Okay, no, it's not the best way to measure anyone under the age of 5. The tympanic membrane is still very small, and these tympanic thermometers are made to fit in people who are above the age of 5. Below the age of 5, your external ear canal is too small to pick up an accurate temperature. So it needs to be done below the age of 5, must be done axilla. Actually, gold standard is PR, but we didn't, in Australia, most places, we don't like to stick a thermometer up the bottom. So the next best thing is to do an axilla temperature. Now, a lot of parents in the community don't like to do it because their children become very upset that when you're trying to hold them to keep still for the 2 to 3 minutes that it actually takes to get an axilla temperature. But yeah, when it's measured tympanic, it's not an accurate temperature. So this fever was associated with a runny nose for 4 weeks, cough for 2 weeks, chesty, no wheeze, no bark. Had some smelly urine in the nappies, no vomiting, no diarrhea, no rash. So eating and drinking is normal when afebrile. Decreased intake when febrile, good wet nappies, and has lethargy with fever. Is there anything we were particularly worried about here?
Maybe a
haven't-
UTI. Oh, sorry, Michaela. You go.
No, that's okay.
Possibly UTI, yep.
Yep, maybe UTI.
Yep. Okay, next slide, please. So just you need a little bit more history. Kids, it's always good to know if they're born at term or preterm, particularly with respiratory presentations, because respiratory presentations seem to be more predominant in children who are born preterm. Normal delivery, no special care. Recent visit to ED 4 weeks ago with diarrhea and vomiting. No regular meds, immunizations up to date, and no allergies. Next slide, please. So socially, lives with the parents and grandparents. They're all currently well. It's an only child, attends daycare 5 days a week. Normal developmental milestones, no smokers in the family, and no significant family history. I'll come back to a few of the social things on a couple of patients a bit later. Next slide, please. So on examination, the heart rate's 142, respiratory rate's 40, SATs are 96, and her temperature is 38.1. But she's a very alert, happy young lady. Right and left ear, there's nothing external, so no erythema on the outer side of her ear. So there's no discharge coming from the ear canal. There's no erythema in the internal ear canal, and couldn't see any of her tympanic membranes because she had a lot of wax in her ear canal. Chest was clear, there was no wheeze, and she had a mild increased work of breathing. She's tachycardic, her abdo was soft, and she's got no rash. Anything you're worried about on this slide? Is she hot and happy?
We
Okay,
have
so
an answer here, Claire, of tachycardia.
yeah, she's tachycardic. Why do we think she's tachycardic? She's got a temperature, yeah?
We have
So
a couple of other answers here for,
Oh.
and her respiratory rate, including the work of breathing.
Yeah. Yeah, so they're both a little bit elevated. Respiratory rate slightly elevated, the heart rate slightly elevated, but then she's got a temperature of 38.1. So she's not very hot, but she is a little bit hot. The things that give you a little bit of comfort here are that she's very happy and she's interactive and she's very alert. She's got no wheeze or stridor, but she does have a mild increased work of breathing, which can be secondary to the temperature as well. Yeah, sorry, next slide. So what do you think is happening at this point and why? There's nothing, you're not going to say anything wrong, don't worry.
We have an answer, Claire, of query tonsillitis or UTI.
Okay. Next slide. All good thoughts? So your initial assessment, I've just put this in here as just a little reminder. So we do this with any of the patients. So the first thing you do, particularly with young kids, probably the toddlers from 9 months onwards, children have stranger danger. So the first thing you want to do is stand back and watch, because as soon as you go near them, particularly if you're in a uniform or you try to do something, they're going to start screaming and crying and carrying on. You're not going to be able to carry out a really good assessment. So stand back and look. Do a rapid A, B, C, D, E. I mean, if they're there looking around and they're laughing, airway's clear, breathing's okay. And if they're running around, their circulation is definitely fine. But if they're floppy and they're lethargic, then you need to get over there sooner rather than later. Okay, you also need to make sure you've had a detailed medical history. The observations must include work of breathing, particularly with your respiratory patients. And always, with every patient, this isn't just respiratory, always look, listen, and feel. Look, listen, and feel. Okay, next slide. So my differential diagnosis for this patient was a probable viral URTI, possible early tonsillitis, and possible UTI. So you've all come up with all of those, which is brilliant. Well done. Okay, so what we did, trial of fluid. We gave an antipyretic. We gave some Panadol and some Nurofen. We did a viral swab. We observed for a while. Pediatric patients need a lot of watching. And then you always review. When you've done any sort of treatment, you always need to give it a certain amount of time before you review it. The next slide, please. So, viral upper respiratory tract infection. So nearly 50% of pediatric consultations are caused by URTIs. The URTI is an effect of both upper and lower respiratory tract and causes inflammation and edema, infiltrates the mucosa, causing mucus secretions and altered ciliary function. The rates are highest in children younger than 5 years old. Children who attend daycares or school are most at risk and easily transfer infections. I think research shows that in the first year of daycare, you will get 6 to 8 viral infections. So think that's like, they don't really get much of a break. The incidence of viral and bacterial URTIs peaks between the ages of 4 to 7, and the treatment is mainly supportive. We get a lot of children who've been referred to the emergency departments who have come from their GP who've already had some antibiotics for a confirmed viral illness like RSV or something like that. Antibiotics are not going to work in viral illnesses. And unfortunately, the treatment is mainly supportive. Viruses will not need antibiotics. Good hygiene is really important, and maintaining immunizations is also really important to stop the spread. Next slide, please. I should have probably, she had an URTI, I thought I had a slide there to say what was wrong with her. The urine was actually clear when we did a dip. It's probably smelly urine because a nappy had been left on too long. And tonsils, you probably did have an early tonsillitis, but that's generally part of the URTI, will show that you got some swollen tonsils. So she was supportive treatment, and she responded really, really well once she'd had the antipyretics and came down. She was fine, she was alert, she went home with some supportive management and follow up with the GP in a couple of days' time. So this is case presentation 2. This is 4-month-old Max. So from his triage notes, he's got a 3-day history of a runny nose and cough. He today woke with an audible wheeze and he was coughing plus. Increased work of breathing, no fevers, slightly reduced wet nappies. He was alert, SATs were 95%, respiratory rate was 40, temperature 36.7, and his triage category was 3. What are you thinking at the moment? In this particular age range for respiratory, there's one thing that is probably the most common. Yes, Kath Lynch, well done. Okay, next slide, please. So it's a 4-month-old male, 3-day history of runny nose. 2 days ago, he developed a chesty cough, worse when he lays down. Continues to breastfeed, but less than about 75% less than normal. Coughs at the breast and becomes breathless very quickly. Slightly less than normal wet nappies, no fevers, no rash, and he remains active and generally happy. Next slide. So again, he was born at term. He was a normal delivery and he didn't go to special care, no regular medications, fully immunized and not allergic to anything. Next slide, please. So he lives at home with both his parents and 2 older brothers. Both currently have a cough and cold. He's got normal developmental milestones. I mean, he's only 4 months, so possibly smiling a bit. Family history, his mum has asthma as a child and the father smokes, but apparently always outside. Any red flags here? Moved on to the next one. Okay, so on examination, he was alert, happy baby, audible wheeze, runny nose, clear. His ears were normal. His throat was a little bit red at the oral pharynx, but his tonsils weren't swollen. He wasn't drooling and he had no pustules. Chest, he had a widespread coarse expiratory wheeze, moderate use of accessory muscles and a tracheal tug. His heart sounds were normal and his abdo was soft. Next slide, please. So what are your thoughts here? Are you worried about him? Yeah.
Yes, we've got worried.
Yeah. So you're right, someone said there's SATs aren't fantastic. They're sort of sitting around the 95%. Someone said something about asthma. I'll chat a little bit more about asthma. We don't generally diagnose asthma in children under the age of 2. So your beta 2 receptors in the lungs are not fully developed until after the age of 2. So you can't formally diagnose asthma until after the age of 2. Until that such a point, you call it a viral induced wheeze. Okay, next slide, please. So bronchiolitis. Bronchiolitis is an acute lower respiratory infection. It affects children under the age of 12, under the age of 12 months, as that's meant to say, sorry, usually less than 2 years. It's mostly viral, and RSV causes 90% of the cases. Other viruses most commonly cause it are parainfluenza and adenovirus. What are you thinking about treatments as we're talking about bronchiolitis? What are you thinking about treatments? It's going to come up soon, so don't worry too much. What treatment do you think this young man needs? Yes, some oxygen. Okay, next page. So the signs and symptoms of bronchiolitis are cough, fast breathing, fast heart, accessory muscle use, recession and tracheal tug, shortness of breath, and a history of inertia. Next page, please. So treatment. So with bronchiolitis, it's ongoing as to what is the flavor of the day. So oxygen, historically given humidified oxygen, and you do it with some pressure. So humidified oxygen is what we usually give to 1 to 2 mil per kilo to maintain SATs above 95. Now there's a draft being rewritten where it's actually to maintain SATs above 93. So they don't worry too much if the SATs are sitting around 95. They have to be above 93. So that's on its way out. Bronchodilators. So what we're talking about just now, they don't work. Bronchodilators do not work because your beta 2 cells are not mature until the age of 2. So if you're below the age of 2, which is when you can get bronchiolitis, bronchodilators do not work. Now there has been some anecdotal clinical thing the way you will try some salbutamol or you'll try some Atrovent to see if that works, and maybe in a small percentage of babies it may work, but it's actually more coincidental than it actually works. supportive treatment is the way forward with bronchiolitis. And again, it's something that parents probably struggle to hear, because what you are going to tell them to do is give small, regular feeds. You're going to give them oxygen if they need oxygen. The best way you can help babies, particularly under the age of 6 months, to make their SATs come up is actually to give their nasal secretions a suction. And that is the most effective way to bring their oxygen saturations up, and then check their oxygen again. So a lot of it is going to be maintain fluids, maintain a good position, so make sure they're elevated slightly. No antibiotics are needed in bronchiolitis. We do not use antibiotics. Next slide, please. Okay, so next case presentation is 6-year-old I. Okay, little girl who presented at triage with 2-day history of cough and runny nose, no fevers, and awoke this morning very wheezy. History of mild asthma, took 2 puffs of her Ventolin at home, no improvement, attended ED. SATs 95%, respiratory rate 45. She was put on a triage category 2. Are we worried about anything here at the moment? Is there anything singing alarm bells?
We have an answer of yes, they have low SATs, including the work of breathing and the respiratory rate.
Anyone want to mention anything about that Ventolin dose? Is that the correct dose for a 6-year-old?
We have an answer of no.
Okay, yeah, that's right. No idea. Okay, next slide, please. So the history, 2-day history of cough, runny nose, and watery eyes. No fevers. Woke this morning with an audible wheeze. Mum gave 2 puffs of Ventolin, did not use a spacer. No improvement, so attended ED. Eating and drinking normally. No nausea or vomiting, and no rash. Next page, please. So previous medical history. So she was born at 36 weeks, secondary to premature rupture of membranes. She was a normal delivery, but went to special care nursery for 12 days. She's been admitted before with asthma. She had no plan, admitted for 2 nights last winter with asthma related to a viral urti. So her regular medications are a salbutamol inhaler, PRN, so when she needs it, the immunization's up to date, and she's allergic to peanuts and grass. So there's a couple of things on this that send a bit of a worry. She was admitted last winter with asthma and a related viral urti. Then she's been discharged with a salbutamol inhaler, possibly without a spacer. So kids need to have, and adults actually, if you are an asthmatic yourself, you should be taking your inhalers with a spacer. If you take an inhaler without a spacer, all the medication just gets stuck in your mouth, and you might get a little bit down in your lungs, but it's not effective. You all need to, there used to be a time where you'd have a small spacer for kids and a larger spacer for an adults. You can still do it that way. However, 1 spacer fits all now. You can all use the same size small spacer. And the fact that she hasn't got an asthma plan, but yet she's been diagnosed with mild asthma, and actually to the point where she had to get admitted with asthma. So those things are all a little bit worrying. Next page, please. Okay, she lives with her sister and younger sister, grandparents and parents. She does attend school. She's got normal milestones. Father has asthma. Mother has a hay fever and eczema. Now, we always ask in respiratory patients about the history of the parents and the siblings, because it is genetically more likely to have asthma if your parents have asthma or grandparents have asthma or hay fever or eczema. Any of that allergy, rhinitis and things like that are more likely to be genetic, so you could pass that on. And the grandfather vapes. Vaping and smoking in the house have been known to be related to increase in respiratory infections and an increase in ear infections. So you always need to ask about smoking in the house and who they're around. Next page, please. So on examination, heart rate was 140, respiratory rate was 42, SATs were 93, and her temperature is 37.1. She was alert, happy young lady, and she could speak in 3 or 4 word sentences. Basically, the ears and the throat were clear. Her chest was widespread wheeze, expiratory wheeze. She had an audible wheeze. She was using her accessory muscles. She was tachycardic, soft, non-tender, her abdos, no rash. What are you worried about here?
The observations and not talking in full sentences.
Excellent, nice. Okay, next, that's so yeah, you're right. That's Rory. She's talking in 3 to 4 words. She was actually very cute, this little girl. She was very smiley and very happy. But yeah, she'd only get 3 words out and then she'd have to take a deep breath in. She's a bit tachycardic. That can be secondary to respiratory rate. Can also be if she has been doing a bit more Ventolin, it might be related to that because that's the side effect of your Ventolin. I doubt it in this case though, because she wasn't taking it properly, B, she wasn't taking it with a spacer, and C, it wasn't the right dose. Next slide, please. So we did burst therapy. So under 5 years of age, it is 6 puffs every 20 minutes for an hour. 24, yeah. So for 3 doses under the age of 5. Over the age of 5, it's 12 puffs every 20 minutes apart. We put a SATS monitor on her. So it's really important with respiratory patients, especially, that you've got a non-pharmacological intervention, and that basically is keep calm, because you can be working an uphill battle when you've got the 2 or 3-year-olds who are fighting you just to get a SATS probe on. Sometimes it's not worth it because they just become really, really unsettled, and it makes their respiratory symptoms worse. You're better off waiting for them to have a sleep or something and then check what their SATs are. So we did a trial of fluids again, because I think I spoke earlier that, you know, the increased oxygen demand will make them breathe a lot quicker. So it actually makes, and with the increased respiratory rate, you exhale an awful lot of water. So there's a good large fluid loss there. So that, along with your normal going to the toilet and that, you need to maintain your fluids. So we normally give, in the emergency department, give them some apple juice because they love it because it's special, and some ice blocks. And then we did some repeat obs, and we must always review the patients. So after 60 minutes, we have a look at post-burst therapy. What other treatments can you consider? Yeah, so at Atrovent, the guidelines say above the age of 12, but I have never actually, I've searched high and low as to why and when to use Atrovent, but it's a very, very hard one to find. They generally, in the guidelines, they use it in moderate to severe asthma. I think it's one of those things that's definitely worth a try, and if it works, do it, and if it doesn't. Steroids again is another one that's very physician dependent. So steroids, definitely worth considering. But generally what we do in ED here is we'll do the burst therapy. If the patient has responded well to burst therapy, we will not give steroids because they're responding well to the salbutamol. If they don't respond well to the burst therapy, we will then give them a dose of steroids. And generally, we'll give them a dose in ED, and then we say go home and give another dose the next day. But we recommend that they give it. It's generally ready paired, and we say have a dinner because it can affect your blood sugar levels. Give the child some dinner, and then give them the patient the steroids, because Ready-Peg can take 4 to 6 hours to work. As you all probably know, asthma, for some reason in these kids, tends to get worse at 2, 3, 4 o'clock in the morning when it's starting to get cold. And that's, if you give the Ready-Peg in the evening, that's when it's starting to kick in, but it hits its half-life between 2 and 4 a.m. So it's actually helpful for them to give it in the evening. But when they're actually in it presenting ED, they haven't responded to the 12 plus. We give them the steroids that we just say tomorrow, give it tomorrow evening, so that it starts to affect in the right time zone. Next slide, please. Okay, so just talking a little bit about asthma. Asthma is a chronic inflammatory disorder of the airways, which many cells play a role in. In susceptible individuals, this inflammation causes symptoms which are usually associated with widespread but variable airway obstruction. That is often reversible, either spontaneously or with treatment. And it also causes an associated increase in airway responsiveness to the variety of stimuli. So dust or pollen can make it worse. Next slide, please. So asthma is the most common chronic disease in childhood. 1 in 4 children are affected with asthma. 80 to 90% of children have their first symptoms before 5 or 6 years of age, and boys are more affected than girls until adolescence, when the trend reverses. Next slide, please. So signs and symptoms: wheezing, usually expiratory, but not always; cough, tachycardia or tachypnea; shortness of breath; chest tightness; increased restlessness; recession and tracheal tug; pale with a malarial flush; and tripod positioning. So they're trying to sit themselves forward so that they can breathe easier. Next slide, please. So triggers, so allergens like pollen and dust, exercise, viral infections, irritants and environmental, temperature changes, medications and emotions are all triggers for asthma. Next slide, please. So the treatment. So aim to the relief of the airway obstruction and restoration of oxygenation and ventilation. So oxygen if needed. So usually if they drop below the sort of 93, 95 mark, we might put some oxygen on. A beta-2 antagonist, so that's your salbutamol, ipratropium bromide, which is your steroid inhalers, or oral cortical or IV steroids, depending on the severity. So you've got mild, moderate, or severe asthma. Severe asthma will also respond to IV magnesium, because the properties of magnesium are a muscle relaxant. So they relax the muscles in the lining of the lungs, so it makes it easier for them to breathe. So quite often, rather than give IV steroids, we'll give the magnesium rather than the steroids, and then we'll give the steroids a bit later. Next slide, please. You can't really see that one. So that's basically your so to look for guidelines, we normally, so I need to be talking like that we're in New South Wales Health. So it's usually the Sydney Child Network guidelines is what we in New South Wales should be working to. However, probably Australia-wide, and actually now getting more and more recognition worldwide, is the Royal Children's Hospital Melbourne guidelines. They're very simple. This actually is from Royal Children's Hospital. They're very, very simple and idiot proof, and they are a really clear explanation and very easy to find. There's apps and there's Googles and there's whatever. The thing that Royal Children's Hospital also have is an app for parents. So we medical professionals get an app with all the different conditions and how you're treated and all the medical side of it, and parents, there's actually a Royal Children's Hospital app for parents as well. However, we work in New South Wales, so we should probably be, I'm not promoting Vic Health, but they are slightly better. Anyway, next slide. Okay, so difference between asthma and bronchiolitis. I think someone mentioned earlier. So asthma, always greater than the age of 2. Don't usually have a fever. The temperature's usually normal. They've usually got a positive family history or a history of any type of allergen, and they respond positively to bronchodilators. Whereas bronchiolitis is less than 2 years old. Fever, you usually have a fever. Doesn't matter about family history, doesn't matter about your allergies, and the response to bronchodilators is negative. Bronchiolitis is usually viral in origin, and as is croup. Okay, next slide, please. So case 4 is of young Hector. He's got a 2-day history of cough. He woke this morning with a bark-like cough and noisy breathing. Fever's up to 37.9 since yesterday afternoon. Respiratory rate of 38, heart rate of 132, SATs of 96, and a temperature of 37.6. He's put on triage category 3, so that's again half an hour. What do you think? Just looking at the triage.
We have possible croup.
Yeah. Excellent. Okay, next page, please. So he's a 3-year-old male. He had 2-day history of cough, low-grade fever since yesterday afternoon, up to 37.9. Another one done with a tympanic, relieved by Panadol, last given at 3 o'clock this morning, and associated runny nose for 4 weeks. Woke this morning with a barky cough and noisy breathing. Noisy breathing now resolved, but continues to have a bark-like cough. No runny nose, no vomiting, no diarrhea, no rash, drinking normally. Slightly decreased appetite yesterday when he had a fever, and he's fully vaccinated. What do you think the noisy breathing was? What's it called? When it's croup, and they have noisy breathing. Yeah, well done, stridor. Yeah. A stridor is a respiratory emergency. So if someone comes into an emergency with stridor, if this 3-year-old boy still had stridor, he goes straight to the emergency to the resus and has some nebulized adrenaline. Because it's about the anatomy. Remember, I was talking about the smallest spaces at the cricoid, and with croup, it's an upper respiratory tract infection that's leading to the croup. So they're getting smaller airways, and when you've got stridor, you've got hardly any air moving in or out. Next slide, please. So previous medical history, born at term, nothing very exciting there. Next page, please. He lives with his mum and grandmother. He's an only child. He attends daycare 3 days a week. Normal developmental milestones. You'll find children who have older siblings and children who go to daycare are most at risk of respiratory, and most of them that come in, probably 90 to 95% will tell you that they are either going to daycare or they've got older siblings. Next page, please. So differential diagnosis. So croup is definitely probably your top one. You do, in certain age groups, 3 years old probably and younger, have to think of a foreign body, because you can get wheeze and stridor with a foreign body. Now, very, very rare. I've worked in emergency departments for 25, 26 years, and I've seen epiglottitis once. We don't see it nowadays, thanks to which vaccination?
We have the hip.
Hib, yes. Thanks to Hib, it's decreased your epiglottitis. Next page, please. So croup is a viral infection, another one that will not respond to antibiotics. It involves the larynx and subglottic area. So I think if you can see in the picture there, it's all upper respiratory. Parainfluenza is the most common cause. It affects children usually between 6 to 3 years. Next page, please. So there's a gradual onset of a stridor and a barking cough. Inspiratory stridor, but can also be expiratory. They get tachycardic, tachypnea, they get fevers, worse at night, hoarse voice. Recession and nasal flaring can be present depending on the severity, and a low-grade fever is very common. Before we go to the next slide, what treatment do we usually give for croup?
We have an answer of nebulizer of adrenaline or to give ReadyPred. And we have another answer of steroids.
Yeah, excellent. Okay, next page, please. So oxygen if needed, corticosteroids and adrenaline. Okay, so oxygen if your SATs are too low, obviously. So corticosteroids, I think, so there's two. There's dexamethasone and then there's Rediped. In community, you're probably more likely to use, unless recently there was a shortage, you're more likely to use Rediped. The issue with Rediped, I don't know if you remember a couple of slides before, is it takes slightly longer for it to get to the half-life. So it takes 4 to 6 hours for it actually to reach the half-life as to when it's going to start taking effect. Oral Dex works a lot quicker. So quite often if it's a severe croup, or even not so severe, we tend in ED to give dexamethasone and then give as an outpatient, give Pred. Adrenaline is if you have a stridor, and that's nebulized of 5 mils of 1 in 1,000, because there's 2 different strengths of adrenaline. You don't want to use the 1 in 10,000 because that's what you use for resuscitation. The next slide, please. So this is treatment. So mild. So this again came from, I'd like to say it was from Sydney Children's Health Network. It's not. It's from the Royal Children's Hospital. So mild children. So you all got the right answers. You consider oral steroids, either Dex or Rediped. If the stridor is present, you need to have an urgent review. So moderate is where you go for your steroids and possibly nebulized adrenaline if the symptoms worsen. Severe is your nebulized adrenaline and always the dexamethasone, not the Rediped. And life-threatening is pretty much the same, and you give some oxygen. And also the dexamethasone, not the Rediped. Next slide, please. So children with any respiratory issues that present to ED, children often require a much longer period of observation in the emergency department. They tend to get better much quicker than adults do, but they also tend to get sicker, much quicker than adults do. Always try and keep children as calm as possible. Make sure they've got a parent with them or a cuddly toy or something that they can help keep them calm. It's not always easy in an emergency department or busy surgeries, especially when, you know, I'm going to be coming at them to look in their ears and look in their throat. It's not a very enjoyable experience for anyone. Always make sure they remain adequately hydrated. I think we spoke about that earlier. Next page, please. So follow-up. In ED, as nurse practitioners, we regularly chase results of tests we've previously sent, and if appropriate, we will make a follow-up phone call with the results. Generally speaking, when children are discharged, we recommend that the children be reviewed by their local doctor in 24 to 48 hours. Basically to ensure that symptoms are resolving, but also to see if there's a requirement for further treatment. Now, put asthma plan in there. I don't know if you remember for my young 6-year-old who was discharged on Ventolin, her GP had never written an asthma plan for her. So she needed to have an asthma plan written and to be taught properly how to be taking an inhaler with a spacer and to be taking 12 puffs, not 2. And they always tell them to return to the emergency department if the symptoms worsen. Next page, please. So this is just where I got all of my information. And the next page. Any questions?
We do have one here, Claire, and it's in relation to dosage of Ventolin. So how many breaths per Ventolin puff with a spacer?
No, it's the same. Everything should always be with a spacer. And if the child is under the age of 5, it should be 6 puffs. If a child is over the age of 5, it is 12 puffs. And most of them, if you've got mild asthma, they should also be on a steroid inhaler. It's usually Flixotide Junior, morning and night, particularly at winter when they're most vulnerable. And that also has to be via a spacer, and they must brush their teeth afterwards, otherwise they end up with oral thrush.
So Claire, if you could just clarify, we just have another question coming through of how many breaths per puff through a spacer?
Oh, you just need 5 puffs between each. Is that what you mean? So you do it and inhale through your space and then 5 puffs. 5 inhales between each puff.
Okay, so we would have, yeah, 5 breaths that the patient would
Yeah.
need to take per puff of Ventolin.
Yeah.
Okay.
By the time they get to 12, they're all dizzy and lightheaded because they've been hyperventilating. But yeah, they've got to take at least 5 in between. Which isn't always pleasant when you're holding down those screaming ones that are 3 or 4 years old. It's not a pleasant experience for anyone when you're doing the 6 puffs for the 3 or 4 year olds. Because you've got to hold that mask on whilst, because otherwise it just sits in the spacer chamber and goes nowhere. And actually, whilst it sounds cruel, if they're crying, it's actually a really good thing when you're doing those spaces, because before they make a big loud cry, they take a massive breath in. So they're actually getting a lung full of the salbutamol, the reliever.
Another question here for you, Claire, is are we allowed to give Ventolin nebulizer in ED? We're not sure post the COVID era.
Yes, you do now. A good question, really good question. It was a long time until you could, but you can now.
Thank you. So we just have a comment here, Claire. So was that under 2 years that Ventolin does not work?
No, it doesn't work under 2 years. There's some anecdotal evidence. People have tried it, and it's usually junior physicians who possibly haven't consulted a more senior physician. But under the age of 2, the beta 2 receptors in the lining of the lungs are not yet developed to be able to diagnose asthma. Anecdotally, there may be some patients that have responded to it, but it's not something that should be done regularly, and it's not something that we tend to do in ED if they're under the age of 2.
We have another question that's come through. So is there someone we can obtain a generic asthma plan for a child?
Yeah, Asthma New South Wales. So if you go onto Google and go to asthma, I think it's either National Asthma or just put Asthma New South Wales, and they've got so much information, and it's really good information. They've got it for healthcare providers, they've got it for asthma educators, and they've got a really good printout that you can give to families for family information as well.
Okay, so we might leave it there, Claire. If you do have any other further questions, Claire's email address is there on the screen. So would it be okay, Claire, if anyone has any
Absolutely,
questions
no
to email
problem.
you directly for that?
Sure, no worries.
That's great. Thank you. That was a really great talk, very informative, Claire. So thank you very much.
Thank you for having me.
So thank you everybody for attending and participating in tonight's webinar. Just a reminder to please complete the online survey that will pop up in your web browser, and we do look forward to seeing you online soon. Thanks everybody and good night.
No worries, thank you.
Thanks, Claire.